All right, good morning. It seems sort of like an ungodly hour to talk about women and drugs, but it's sort of like my favorite topic, so I'll try to wake us up a little bit. I also feel like at this conference, I'm sort of like the mini mental health counselor. And as I've done my talks today and tomorrow, I sort of feel like there's kind of a life lesson in each one of my lectures. And so the life lesson, I'll put it out there up front for today, is let's try to be kind to others. And you'll see as we go through and we talk about women who have substance use disorders, stigma and shame is a big part of how these women are treated in our community. And so as healthcare providers and leaders, we can sort of show the way for our colleagues about addressing this fragile population with respect and the courage they deserve. So let's get started. So substance use among women is on the rise. Women now represent the fastest growing segment of substance users in the US. The most recent national survey on drug use and health revealed that about 45% of people aged 12 and older who use illicit drugs are women. That's increasing. An estimated 4.5 million women have a substance use disorder. 3.5 million abuse or misuse prescription drugs, and 3.1 million regularly use illicit substances. This costs about 200,000 women their lives each year. That's pretty staggering. And the way women manage addiction is different from men, and the more research we do about this, the more we learn that. So from a biologic perspective, there are unique characteristics related to hormones, pregnancy, breastfeeding, and menopause that impact a woman's progression from early use to addiction and then through to recovery and what her recovery looks like. Women are known to experience a phenomenon known as telescoping, which means that they progress from first use of an illicit substance through to dependence and addiction much more rapidly than men. And they also experience more negative health and social consequences more quickly as a result both of biologics and their psychosocial circumstances. So from a psychosocial perspective, we know that women tend to seek medical care more often than men, and for that reason, they are more likely to be prescribed medications, including narcotics. Women tend to use illicit substance use as a way of coping with emotional stress and trauma, and we're going to look at that trauma in just a minute. And we know that substance use in women can often be driven by weight management drugs and also driven by this idea that they'd like to be the mommies that they see now on social media, right? We have a big campaign about mommy juice, right? About drinking wine, and that's part of the culture now, and it's cool and hip, when really it's sort of twisted. So we know that pain and trauma are common drivers that fuel substance use. Adverse childhood experiences that I spoke about last year and interpersonal violence increase a woman's risk for substance use. Women also suffer more frequently and more intensely from pain. We've known this for decades. And so they're usually prescribed more narcotics for pain relief. And part of it is also our misconception that we sort of believe that men tend to progress to addiction more readily than women. And so they've looked at prescribing practices and found that physicians tend to prescribe more narcotics more easily to women because we don't have the thought in our head that they're going to become addicted or substance users. Women are also more likely to suffer from chronic pain syndromes like fibromyalgia and osteoarthritis, which then leads them to being prescribed more narcotics. Mental health history also significantly increases risk, and women are twice as likely to suffer from depression and anxiety than men. And it becomes a vicious cycle, right? You're a child, you experience trauma. You grow into a teen, a young adult who experiences more trauma. That trauma then already magnifies, exacerbates your biologic predisposition to depression and anxiety. That then leads you towards substance use or increases your risk. So you can get stuck very quickly. So when they look at trauma and addiction, you can see in one of the first studies, close to 75% of addicted women report experience sexual abuse, and women who have had traumatic childhoods, so have been victims of trauma, abuse, neglect, are 5 times more likely to use drugs and twice as likely to abuse alcohol than those who did not. And as many as 4 out of 5 women seeking treatment for substance use disorders report a lifetime history of sexual assault, physical assault, or both. And lots of people will say those numbers are low, that if they look now, it might be as high as 90% of women who are in substance use treatment have experienced trauma. And so there's this new focus on trauma-informed care. Has anybody heard the buzzwords, those buzzwords? I can tell you're very awake this morning. I see a lot of head nod. No, just kidding. So what trauma-informed care means as a physician and as a clinician and as a nurse and whatever your healthcare practice looks like, that your team is sensitized to the idea that the women around you are likely sufferers of trauma. And your main goal in knowing that is to not re-traumatize your patient. So that's the environment you're trying to create, an environment of safety and security that then restores power to your patient. And you can do that by honoring the trauma, by asking about it in sensitive ways, and also then getting those patients who have suffered to effective treatment, therapy, groups, if they need substance use treatment, that relationship counseling and the like. But it's become a pretty important part of all we do, seeing that trauma has become such a big focus in our day-to-day existence. So women are subject to greater stigma in seeking treatment. Just like I started this lecture saying that shame and stigma follow women who have substance use disorders around. Can you imagine you're a mother of 4 and you're at home and you've developed a habit with oxycodones from your husband's mother and you're taking them every day, and the thought of telling the ladies who lunch that you're going to go to substance use treatment because you've been stealing from grandma, doesn't come out that well. So women generally tend not to ask for help because they're terrified, 1, that it will ruin their reputation, 2, that they'll take their children away, right? Men don't face that. I've rarely heard one of my male patients worry that, like, if I go to treatment, the kids are in danger. But almost universally, every single woman wonders, who's going to take care of the kids if I can't? Will CPS be called and will they take them? And how will I manage my life if that's the case? And so we know that although 1 in 3 people with substance use disorders is a woman, only 1 in 5 are in treatment, right? So we have a ways to go to catch up, to make it an accepting environment. And part of that too, I think, relates back to the trauma-informed care, that the services we're providing actually are women-centered, deal with the unique issues that face women in substance use treatment. And we know that by the time women get to treatment, because of the fact that they're afraid to seek help, they often face greater medical, behavioral, psychological, and social difficulties. So what tends to happen is these women sort of stay in hiding. The problems escalate until they come to the attention of the law or DSS, and that then prompts them into treatment. And by then, they've dug a hole so big they feel like they can't get out. It's not true. You can, but you've already subjected this poor woman to a lot more consequences than maybe had to be if she had had an attentive listening ear from a clinician that got her into treatment sooner. And the good news is that the women who do get into treatment do better than the men. And part of the thought behind that is that women are much more likely to engage in psychotherapeutic groups, to be part of counseling, and that in terms of substance use treatment is fantastic, is very helpful. So breaking it down, I'm going to look at alcohol, methamphetamine, and my favorite topic, women and opioids. Woo-hoo! But let's start with alcohol, an old favorite. So according to the CDC, 46% of adult women report drinking alcohol in the last 30 days, 50% nearly. 12% of adult women report binge drinking, and this binge drinking is going to come up at the bottom of the slide. Binge drinking 3 times a month and averaging 5 drinks per binge. And when we get to the end of this little section and we hear what the AMA has to say about regular drinking levels, you're going to know that 5 drinks isn't a good thing. About 2.5% of women, 4.5% of men met the diagnostic criteria for alcohol dependence in the past year, and that's out of 2014. So it's believed to be a little higher, maybe 2.7 now for women. We're catching up to men, and that isn't something we should be proud of. We know that female alcohol use disorder in the United States increased by 83.7% between the decade 2002 to 2013. That's not good, and like I mentioned above, national surveys show about 1 in 2 women of childbearing age drink alcohol, and 18% of women who drink alcohol in this age group binge drink. And those binge drinkers are at risk for quite a number of things, as we'll see. So the slide's small, the point being, women and alcohol sort of do not mix. And part of the reason for this is, again, biological. Women absorb and metabolize alcohol differently than men. They have less total body water, and so the same amount for the same weighted man, same amount of alcohol will affect a woman more severely than the man. They also have lower activity of aldehyde dehydrogenase, so they experience a higher blood alcohol content after consuming the same amount of alcohol. So off the gate, you're already in trouble. You cannot compete with your husband, your partner, your friends. Women will suffer more consequences every time. And we know that women who drink more are at risk for abuse more. And so the cycle then again continues. Women who drink more are at risk for more mental health issues. Same cycle. We see abuse, mental health, substance use connected in a revolving wheel. We know that alcoholism affects every single organ system negatively. There is not one. I'm an inpatient psychiatrist for half my day, and I can't tell you how many stories I hear from my patients about, well, I've heard it does really great things for your skin. Or I think it's really good, I've heard it's good for your heart, right? It's like universally untrue. You can say to your patients, there is not one good thing from a biologic standpoint that alcohol does for you. We know it causes liver disease and cirrhosis. In terms of its impact on the brain, it predisposes you to brain shrinkage and loss of white matter. That's not good. And when you're a woman, you're at increased risk over your male counterparts, right? So memory, cognition, sensory processing all decrease, especially as you age with increased drinking. We know that it impacts your heart muscle. It weakens it, predisposing you to a heart attack. It causes cancer, not just of your liver, but in women in particular, you have a predisposition to breast cancer. And as a breast cancer survivor, let me just tell you, it's not that fun. You don't want it. Stop the drinking. And like I said earlier about the binge drinking, women who drink more in a binge drinking situation are subject to sexual abuse. So binge drinking is a risk factor for sexual assault. Each year, about 1 in 20 college women are sexually assaulted, and research suggests that there's an increase in the risk of rape or sexual assault when both the attacker and the victim have used alcohol prior to the attack. And this cannot be that surprising, but when you're counseling your younger patients, it's something you would like to keep in mind. Alcohol also changes our reproductive health. So we have changes in HPA axis regulation, delayed puberty in young people, increased risk of breast cancer as you age, and disruption of menstruation and increased risk of infertility if you're drinking through your childbearing years. And phenomenally, we have lots of data on pregnancy. Women still drink alcohol during pregnancy. About 10% of women are still drinking during pregnancy for a variety of reasons, but none of them probably that good. Women who drink alcohol while pregnant increase their risk of having a baby with fetal alcohol spectrum disorders. Excessive drinking increases the risk, we know, for miscarriage, stillbirth, preterm delivery. And women who drink alcohol while pregnant are also more likely to have a baby die from sudden infant death syndrome. And this increases substantially the more they drink in the first trimester. And you can imagine a lot of women don't even know they're pregnant in the first trimester. So if you're already drinking alcohol regularly, or you're subject to a binge drinking, then you're much more likely to put your baby at risk without even knowing it. So I think it's wise to counsel your patients, listen, if you want to get pregnant, if you're thinking about it in the next year, like at your annual checkup, I'd stop the drinking. Like, just prep the body for what's going to happen. You don't need it. Get rid of it. Okay, so this is what the ADA and NIDA say about low-risk drinking limits. So for women, it's no more than 3 drinks on any day and no more than 7 in a week. I can't tell you how frequently I quote this to my patients because people really don't realize it. And they're simple, easy things to give patients to have a target to shoot for if you want to be low risk. So that means the chances of then developing, right? Because there's a difference between risky drinking and then having a substance use disorder. And so what this looks at is keep your risk low all the time. Don't progress into risky drinking, which would be above 4 drinks or more in a day or more than 7 in a week, because once you cross that line, the chances that you're going to develop a substance use disorder increases about 10 or 15-fold. It's a big deal. I keep this posted in my office just so people can see it. I often print it out for people to take home. It's an easy infographic that helps patients have a standard to shoot for when you think they're at risk for heavy drinking. Okay, so let's change over to women and methamphetamine use. How many of you have seen a methamphetamine increase in your communities? Okay, good. So a fair number of you in my community in rural Southwest Virginia, it is a tremendous increase. It's like the second coming of the opioid epidemic, and it's tragic. And for many reasons this is happening. Meth is easy to make, it's cheaper to sell, and so I think it's having a great resurgence in our country, especially as opiate regulations are being more tightly managed, and the in-stream of opiates into our country has lessened. Methamphetamine use has skyrocketed. So according to the 2017 National Survey on Drug Use and Health, over 14.7 million people, that's 5.4% of our population, have tried methamphetamine at least once, and almost 1.6 million used in the year leading up to the survey. A 2009 report by the RAND Corporation noted that methamphetamine misuse cost about $24 billion in 2005, so you can imagine a full decade how much that's increased. And studies confirm a spreading pattern of methamphetamine use from its initial concentration, predominantly of white women in the West, to increasing numbers in the Midwest and Southeast, including increasing proportions of Hispanic and Latino women. And I think some of what's driving this is what I mentioned earlier about women trying to keep up with the Joneses, what they see on social media. I have a lot of psychotherapeutic groups with women who, when I ask, like, why the meth? Like, where's the great, drive to do that? And they'll say, well, I had to pick up the kids at school and clean the house, and my husband doesn't do anything, and this gives me the perfect amount of energy, and then ... and I'm great in bed. So there's a connection between methamphetamine use and sex that also warrants investigation if you're talking to a patient who's a woman who has an increasing methamphetamine use problem. So part of what we're watching too is that methamphetamines are contributing more and more to overdose deaths in conjunction with opiates. So opioids are the reason they actually die, but methamphetamine is more and more commonly associated in the bloodstreams of those people who are dead, and part of it, right, it's an upper and a downer. So when you're 2 down, you take a little meth, you come up, you're able to function, you get home from work, you take a downer, the cycle continues. And you can see it's still increasing all the way up to 2017. It increased in 2018, and we're waiting for 2019 stats. Like alcohol, methamphetamine doesn't do much for you. So as much as my patients love that they have so much energy to do the vacuuming and feed the babies and get off to work, I try to emphasize to them that you're killing yourself. Like most uppers, it is particularly dangerous on the heart, predisposing you to heart attack, irregular rhythms, and sudden cardiac death. It does hurt liver, lungs, brain, your reproductive system. I think we're all familiar with what it does to your teeth and your general health. People who are using meth chronically tend to have a lot of scabs from picking. It's something you can often pick up. Sometimes I won't have seen a patient for 6 or so months, and they show up and they look like they have chicken pox. And you'll ask, like, what's going on? They'll be like, oh, I'm not sure what's going on. Like, I don't know, it's a rash from the sun, or, oh, I fell and got some bug bites, or, right? And you have to think, the first thing I think, of course, this is my practice, but you too can think, I wonder if there's a ever-evolving methamphetamine habit. And you can ask, like, hey, have you ever had any problems with illicit drugs? Or more and more commonly, right, moms are taking their children's Adderall, Ritalin. So that's something to ask about. We know that women tend to use methamphetamine use at earlier ages, but like in the alcohol department, they respond better to treatment than do men. Methamphetamine appears to be associated with depression in women, and women seem to be more committed to methamphetamine use, meaning they get stuck on it for longer. And it's not surprising that methamphetamine and depression are connected, right? You have a high of methamphetamine, you're going along, you're doing everything, and then you stop using and you can't function. And when you're a mom and you can't function, you go to that guilt and stigma place. You're a bad person, you're a bad mom, and if you're predisposed to depression, then here come your overriding depressive symptoms. Women may be more prone to psychotic effects after methamphetamine use, so there's early studies that tell us that, but it's not definitive. And just like I mentioned that there's this connection between methamphetamine and sexual activity, because of that, women who are actively using methamphetamine as a means of improving their sexual response are at increased risk for HIV and sexually transmitted infections, which is, pretty major. And in pregnancy, among pregnant women, admissions for treatment of methamphetamine abuse increased from 8% of federally funded treatment physicians in 1994 to 24% in 2006. And a lot of this happened in the western states. That's where meth sort of originated, and now it is spreading over to the Southwest. The risk of small for gestational age and low birth weight babies is consistently increased with methamphetamine use in pregnancy. Methamphetamine use appears to be associated with neonatal and childhood neurodevelopmental abnormalities, including deficits in attention, visual motor integration, verbal memory, and long-term spatial memory. That's not small, and the data as of yet hasn't told us if the children catch up by the time they get into elementary school. So these are all for early learners. Amphetamine use also inhibits prolactin release that can reduce breast milk supply, and we know that the concentration of amphetamines in breast milk can be as great as 7.5 times higher than those found in maternal plasma. So you sort of have two hit. First, the amphetamine decreases your prolactin, but also if you have a woman who's using amphetamines and you know it, or she pops with a drug screen that has amphetamine in it, you're going to counsel her not to breastfeed because it's dangerous. Okay, so women and opioids, my favorite topic of all the topics. I sort of like to get on my soapbox about this. How many of you in the room are buprenorphine providers? Oh, I have my lone savior in the back. I'm just going to do a little shout out. I really encourage you to consider, if you're in general practice, if you're family practice, if you're internal medicine, like your help is desperately needed to help treat opioid dependence in women, and the course is easy, and you just do your dispensing a couple of times and you will get very comfortable with the prescribing practices. It's not hard and it saves lives. Did you have any problem doing it, or it's pretty simple, right? So just shout out to think about it. Okay, so we already know we have a huge opioid epidemic. This is not the first one in the last 100 years, it's about the third. So at the turn of the century, there was one. About coming back from the Vietnam War, there was another great influx of heroin. And right now, in the last 2 decades, we're in the third coming of the opioid epidemic. About 2 million people have an opiate use disorder in our country. 2 million have misused prescription opioids in the last year. We have about 15,482 deaths attributed to heroin alone, and our synthetic opioids are on the rise. About 130 to 132 people die every day from an opioid-related drug overdose. These are numbers that are unprecedented in our history. It's the biggest number of deaths in all the waves of opiate use we've seen in the United States combined. And people are still dying. The opioid death rate reached its peak of 14.9 deaths per 100,000 people in 2017, but we've made little progress. It hasn't jumped much farther, but it certainly hasn't gone down despite all the regulation that's going on. From 1995 to 2015, deaths from prescription opioid overdose increased 471%. And deaths from synthetic opioids, like I told you, it's the influx into our communities is huge. From fentanyl, skyrocketed 850% among women. For those of you, you probably don't do this, but in my practice, I have about 100 women on buprenorphine, and I regularly drug test them. I can't tell you how many times the women who are illicitly using opioids pop positive for fentanyl as well, that there's a component almost in the drug supply of these synthetic opioids that are incredibly dangerous, particularly when mixed with benzodiazepines. So just a brief history of these last 2 decades. In 1995, the American Pain Society created the 5th vital sign, which was pain, and it was a whole bunch of bullshit. It was, sort of crazy how pain became this targeted thing that we had to measure. And then Purdue Pharma, who is under quite a bit of scrutiny right now, came to the rescue with OxyContin. And they had all these fantastic marketing things, and they brought doctors to fabulous resorts like this, and they gave them goodies and incentives to prescribe OxyContin, and pretty soon we had a very large problem on our hands. In 2002, doctors in the United States prescribed roughly 23 more times OxyContin than in 1996, a 5-year jump, and sales of the drug increased more than 30-fold. And so in 2009, the U.S. was the vast majority of the prescriptions for the world's opioid painkillers, including 99% of all hydrocodone and 81% of oxycodone. So we're trying to come back from a tremendous influx of opiates into our into our communities, the larger healthcare system. And knowing that, and what we read earlier, that women are more likely to have chronic pain syndromes, be prescribed narcotics more easily for greater amounts for a longer duration of treatment, it's no wonder that women make up nearly equal parts of the opioid epidemic. They were rife to fall prey to this problem. So compared to men, just like I said, women are more likely to have chronic pain, be prescribed pain relievers at higher doses for longer periods. And then because of that telescoping, it's like they had no chance. they are more likely to experience negative health, social consequences as a result of a smaller amount of use. So they were crippled from the start. We know every 3 minutes a woman goes to the emergency department for painkiller misuse or abuse. Women make up 65% of total opioid prescriptions, and 40% more women than men become persistent opioid users following surgery, right? And it's that same thing where they likely went home with more medication than their male counterparts that then predisposed them to taking more for a longer period of time. Their biologic predisposition meant that that amount affected them more severely, and therein you can see how an addiction takes over. This is interesting. Opioid prescription rates are substantially higher among Medicaid patients. One study revealed that 40% of Medicaid enrollees with opioid prescriptions had at least one indicator of potentially inappropriate use. So 40% have potentially inappropriate use. And then you look at women make up nearly 70% of the adults on Medicaid. So that's a lot of people with inappropriate use. So let's look at pregnancy and opioid use disorder. This is what I was talking about in terms of becoming a buprenorphine provider. Buprenorphine, as we're going to see, provides life-saving treatment, and I encourage anybody who's involved in the care of women or women's life cycle, the reproductive life cycle, that you consider becoming buprenorphine waivered. So when I meet women who are pregnant and have an opioid use disorder, I recognize it as the intersection of the reproductive life course and the substance use life course, and just being a woman's life course, right? Pregnancy is a unique period where they have social contact, they have health insurance, they tend to go to the doctor more, they take medications more consistently. There's a window of opportunity in this time for behavioral change. What woman who's pregnant doesn't want to do better for her child? And I see this so often, that women who are pregnant are much more motivated to do something for their child than they were to do something for themselves just 2 weeks earlier. Once a child is on board, all bets are off. Any change is possible. It's really remarkable. And so how we talk to our pregnant patients is important. This is where I come to the life lesson of be kind to others. There's a lot of shame and stigma around substance use and addiction, and we sort of need to turn that around. Not even sort of, we need to turn that around. It's just nobody gets better being shamed. Not one of us probably in this room does a whole lot of good being shamed. They actually do a lot of psychiatric research on this, and we're going to talk more about this tomorrow, but shame causes isolation, withdrawal, and worsens psychiatric symptoms. A little bit of guilt, probably all of us when we were little did something bad and our mother guilted us to do something better. That works. A little bit of guilt will work. A little bit of shame will shut you down every time. So we need to change the narrative. Like, stop thinking, I keep waiting for, these are my pipe dreams when I'm awake at night, when like substance use disorders can be equivalent with cancer or diabetes. Like, why don't we have substance use disorder walks? And, you know, why isn't there fundraising for substance use disorders? You know, instead, whenever we talk about substance use disorders, it's frequently, you know, followed by a talk on the legal system, or frequently followed by a talk on prisons and jails, instead of like, ooh, we raised $25,000 for those pregnant women with opiate use disorder. I mean, the problem is profound and extremely large, and by shaming people and making them fear coming to treatment, we do absolutely no good at all. So we have to learn to use medically appropriate terms. We have to recognize our biases. I deal with these women every day. They're pains in the asses. I'm just here to tell you, I love them. Oh, sorry. I love them, but it's hard. It is not easy. They are trying. They are used to getting what they want, when they want, how they want it at this very minute. It takes a lot of patience, but they're hardworking, loving mothers, committed to recovery, which is a lot more than all of us in this room can say. If you think about a problem that you're trying to tackle and you've put it off for a decade or more because it seems too hard, right? These women who I treat are actively engaged in getting better, and that's a pretty fantastic thing when you think about it. I try to use an open and non-judgmental style when dealing with these people, and I try to talk to my colleagues about the myths associated with substance use disorder. So it's not a moral failing. Are we all clear on that? It is a biologic disease. It is based in the brain. We've done a lot of studies about it. There's not really debate. It's not because they're bad people who got off on the wrong side of the tracks, right? Happens to everybody. In this room, 1 in 10 of us has a substance use disorder. 1 in 10. So what are there, 50 people in here? So 5 of us are struggling right now, or maybe 1 of us is in recovery. We know that it's a myth that punishment works better in treatment. It's that same thing I just talked about shame and stigma. They don't work. Open-mindedness, non-judgmental attitudes help people admit that they're having an issue and seek treatment. She could stop if she wanted to. There is no pregnant woman on the face of this earth that feels proud that she has a substance use disorder. So if she could stop, she would. It's almost pathognomonic that if you are using substances and you are pregnant, you have a clinically significant disease of addiction that needs treatment. And it's not because you don't want to stop, it's because you can't. Because the neurologic pathways driving your addiction are far stronger than any moral or personal compass you have that tells you not to do it. And some people say it's easy to tell who's on drugs. Well, we all can look around, and I'm not sure we could pick out the 5 people in this room who are on drugs. So that's not true either. And relapse equals failure. It's not true. So like any long-term thing, any of us who have struggled with their weight, any of us who are trying to exercise more, all realize that, yes, I had the carrot cake last night. Yes, I went to Ben & Jerry's. Like you're on a wheel. You get better one day, you fall down the next, you stand up the next. Like the idea is over the long term, we're headed in an upward trajectory, but every day isn't perfect. Relapse, slips, 1 or 2 days picking up a new illicit substance are part of getting better. So I also think it's important to monitor the terms we use. I struggle with this even. It's very hard to change words you've been using for a very long time. I was going to share a story about, I have a very hard time. The word retard has been taken out of our common lexicon, and for good reason. And I completely support that, but I have to tell you, it was one of my favorite words. And not for mocking human beings, God no, but just like more for personal reflection. Like I'd be like, God, I'm a retard. And I had to take it out, and I have to tell you, it took me a really long time. Like it's very hard, and I've moved on to the word moron. And it just doesn't seem to hold the same grit for me, but I just tell you that because it's hard to do, but it's really important. So addict, we don't use it anymore. Why? Because it's stigmatizing, because we've talked about it for years in a shameful way, and so that confers, that word now is ugly, it's negative. So we try to take out abuser, addict, junkie, right? All those are shaming. And I say a person with a substance use disorder. So that doesn't flow off the tongue quite as easily. But it's part of what we need to do to respect our patients and help them learn to use the language that builds respect in themselves, right? That builds self-efficacy. I don't talk about clean or dirty urines. I say they're positive or negative, inappropriate or appropriate. I don't use habit or drug habit at all. Again, negative and shaming. And I use opiate replacement or medication-assisted treatment instead of methadone maintenance, because it makes you feel like you're going to be on it forever. And maybe you are, and that's fine, but we don't need to emphasize that. We use medically appropriate terms. So Looking at pregnancy and substance use disorder, there's a tendency to believe that women aren't doing really well, except compared to non-pregnant women. Pregnant women drink less alcohol, smoke fewer cigarettes, and use fewer illicit drugs during pregnancy. So just by virtue of being pregnant, nearly every woman is motivated to change her behavior, and they do. We watch use decrease over the course of the pregnancy, but the greatest reduction is actually seen pre-pregnancy or in the first trimester. And the reason I put that up there is to encourage all of us to be very aware when someone first is diagnosed as pregnant, first finds out they're pregnant, it can be a critical period of change. So that's when you can jump in with resources to help a woman who does have a substance use disorder seek treatment. And we know that 80% of women who stop using any illicit substance or alcohol or even tobacco resume postpartum, which seems like, oh, that's too bad. Except, I like to flip it over, that's 20% of women who continue to stay stopped from their substance of abuse, which is major. For a single intervention, pregnancy is like, woohoo, let's get everybody pregnant. Just kidding, let's not do that. We know that opioid misuse in pregnancy has direct effects on a fetus, including neonatal abstinence syndrome, or what is now being called neonatal opiate withdrawal syndrome. See, we're watching a change even still because neonates can't be abstinent, right? That doesn't make sense, but that's the lingo that caught on, and now we have to move to one that is more medically appropriate. We know that they have stunted growth, preterm labor, fetal convulsions, even death. And outside of that, the babies and the mothers are at risk for indirect things like maternal STIs, HIV, Hep B, Hep C, malnutrition, and poor prenatal care, because when you're active in a drug culture, you're not as focused on taking care of yourself and your baby. And then you're also subject to more violence, interpersonal partner violence, as well as gun violence. And you're at risk for incarceration as a result of all of that. And we can see that the amount of pregnant women is still increasing. 49 addicted mothers per 1,000 deliveries is the rate quoted. Now, neonatal abstinence syndrome, while we don't like it, neonatal opiate withdrawal syndrome, we recognize as an expected and treatable consequence of opiate use in pregnancy. It is not my mothers feel so ashamed that their babies might suffer from this. And I really emphasize to them, this is an expected and treatable result of life-saving treatment to keep you able to function as a parent and raise your child and live a productive life. So 4 days, 6 days, 2 weeks of your baby being fussy, irritable, and crying is well worth the effort. I'm not saying that I want babies to suffer from this. I most certainly do not, but in the grand scheme of things, I think the risk-benefit ratio is far in favor of the woman being on MAT. We know that NAS increased nearly 5-fold nationally between 2000 and 2012. About 50 to 90% of opioid-exposed neonates exhibit NAS, and the hospital costs, this is where our hospitals tend to get involved, it's about 5 times as much, $9,000 for a regular birth, $54,000, $56,000 for a baby suffering from NAS. So what do we do for that? We do medication-assisted treatment, or the use of buprenorphine and the combination product Suboxone or methadone in pregnancy for women who have opioid use disorder. So MAT in pregnancy treats the underlying neurologic perturbations with substance use disorders with medication. It stabilizes the intrauterine environment by reducing the repeating cycles of opiate intoxication and withdrawal in the pregnant mother. So if a mom's out and using, it's a constant cycle between getting high and then being in withdrawal, getting high, being sick, being in withdrawal. And if you can imagine, if the mom's experiencing that, so is the baby. So when we replace that use cycle with a stable buprenorphine dose or methadone, women do better, babies do better. Detox is not recommended. It's been looked at 1 million times. It will probably be looked at 1 million times more. I'm not saying in very specialized circumstances. It's not something that is, it's a double negative. It is used sometimes. It is rare. It is used by people who do this very regularly. I've done it once in the entirety of my practice, so it is not to be encouraged. I don't think. What I find, women who are like, I'm just gonna stop, generally suffer from a lack of education. And so when you provide the education, what I just discussed, their risk of relapse, the risk of re-exposure, of that repeating cycle of intoxication and withdrawal, of exposure to HIV, violence, Hep C, it becomes far more important that women stay on medication-assisted treatment or move from illicit drug use to medication-assisted treatment than try to withdraw. Medications, as I said, include Suboxone, Subutex, or Methadone. What it does, just like I said, it creates a stable intrauterine environment. It decreases the use of illicit substances. There's a reduction in HIV and Hep C and other high-risk sexual behaviors, and also trauma. We watch women who are part of MAT programs have increased prenatal care adherence. Their babies are bigger. They stay in the mother longer. Women have a decreased risk of overdose and death, and they're also more engaged in psychotherapy and mental health care. So it's a very good thing. Benefits of MAT compared to untreated pregnant women. Women with methadone or buprenorphine have infants with a lower risk of neonatal opiate withdrawal syndrome. They have less severe neonatal opiate withdrawal syndrome. They have a shorter treatment time in the hospital. Their babies are bigger and they have bigger heads, indicating they are healthier. Every major medical society in the world, emphasize world, supports MAT. It is fantastic. It changes people's lives. So the takeaway is pregnant women are motivated to maximize their health in pregnancy. If they can't, right, like I said, it's practically pathognomonic. If you're using a substance in pregnancy, it's because you can't stop because you have a substance use disorder. And given their unique set of needs, the fragility of their social circumstances, they deserve our compassionate, non-judgmental, and comprehensive, care-coordinated efforts. Teamwork makes the dream work. Okay, that's all.